Okay, thank you all for the invitation today. Thanks tomorrow, and I'm happy to be with you all, albeit not be in Brazil. I wish I could be with you all. My name is Richard Elion. I'm a clinical professor of medicine at George Washington, and I work at the Department of Health in Washington, D.C., where we provide post-exposure prophylaxis. And I'd like to talk about how post-exposure prophylaxis is in some ways not utilized enough and can be a bridge towards prevention. Let's start with a case. This is a 31-year-old male who has sex with other men. He reports a sexual exposure within the past 24 hours, no condom use. He went to a party that had some drug use. I'm sure that's just as common in Brazil as it is in the United States. What you can see in terms of his laboratory values are, for the most part, everything is negative when he comes in. His antigen test is negative, his viral load is negative, STI screening is negative. Most of his tests are pretty good. So he comes in really with just a history of something that you're concerned about, but no lab values to suggest that he's got any kind of infection. And the question is, what would you do? Here's an algorithm for looking at what you would do. So first of all, we decide if this patient has had substantial risk for HIV acquisition. And one of the first things is, how long has it been since they were exposed? If it's less than 72 hours, you're still at a point that intervening with medication would be efficacious. If it's more than 73 hours, then it's too late to make a difference. And the other assessment is if there's a negligible risk. Negligible risk for HIV is exposure in the various body parts that you see there with semen, and regardless of the known or suspected status. We don't look necessarily at the HIV positivity of the exposure. We assume that it could be positive, so thinking it was negative wouldn't change your judgment. So in this case, he had sexual contact, and so the thought is he's had, and it's less than 72 hours, so he would be in the group on the left, less than 72 hours since exposure. If his source patient was known to be positive, well, for sure you're going to do post-exposure prophylaxis. And I think in cases where the source patient is unknown, you still end up recommending PEP. If you're in an area where the demographics or prevalence of HIV are high enough, you can't assume that the person is negative. And you have the ability in a short period of time to make a difference in terms of his risk of acquiring HIV. So even though it's listed as case-by-case determination by the CDC, I think that we really think of that as a possible exposure. Now, what's considered the risk of exposure? You can see the same areas of exposure as we saw in negligible risk, but the difference is what the exposure is with: blood, semen, secretions, rectal secretions. Any body fluid that could be contaminated with blood is different than before, where we said no appreciable exposure, which is urine, nasal secretion, saliva, sweat or tears without visible contamination of blood, or if the source would be known to be positive. So in summary, I think if it's less than 72 hours, if there's an exposure of anything related to semen, blood, or vaginal exposure, those are the issues that you would be looking at this to make a decision. What are the preferred regimens? There are two preferred and alternative according to the CDC guidelines. And I don't know how it is locally in Brazil. And this is for adults or adolescents greater than 13, including pregnant women who have normal renal function. So that's one test you'd have to take concomitant to the time you'd start medication, and discontinue the medication if these tests come back negative in the next 24 to 48 hours. The preferred regimen is a 3-drug regimen of FTC, tenofovir, and either DTG, dolutegravir, or raltegravir. Dolutegravir is given once daily, raltegravir is given twice daily. An alternative approach would be a 3-drug regimen with, instead of dolutegravir or raltegravir, the protease darunavir, along with ritonavir, given once a day, as well as FTC TDF. There are other regimens that have been used, such as bictegravir, TAF, and FTC, but these are currently the CDC recommended guidelines. There was an open label study looking at bictegravir, FTC, and TAF for 28 days. You can see here the population that it looked at with the demographics of mean age of 37. Sexual behavior, about over half of the patients had receptive anal sex, and another 22% had insertive anal. Receptive or insertive oral made up 30, but vaginal made up a very low number. So this, for the most part, was sexual contact, for the most part, between MSM with less heterosexual exposure. The data showed very well tolerated. When you looked at this compared to protease and 3TC and zidovudine, you saw improvements in less diarrhea, less fatigue, and less incidence of headaches without other significance. So for the most part, it was well done, well tolerated, and the completion rates were in the bictegravir arm 90% compared to only less than 40% in the zidovudine-containing PI arm. In raltegravir and FTC TDF close to 60%, elvitegravir with COBI, FTC, and TEF 71%. We don't have a comparison here between the current recommendation of dolutegravir or of dolutegravir. We just have it with raltegravir. So part of the keys of this approach is both a regimen that's going to be well tolerated because the person is certainly not at huge risk, and two, to make it a regimen that the patient is likely to continue. The recommended laboratory monitoring for this at baseline would be HIV antigen testing, HPV, HCV, syphilis, gonorrhea, chlamydia. You don't necessarily need creatinine at first, and ALT and AST. At baseline, this is for the source, at baseline for the exposed individuals, you do need creatinine, ALT, AST, and everything else. I think it's very common to do HIV PCR at this time to make sure there's no early exposure based on anything before that. And at the 4-week exposure, again, you're looking just in the CDC recommendations, just antigen antibody testing. There's also some people who might recommend PCR testing, but really no real need for that. When you're out at 4 weeks, there's been plenty of time for that antigen antibody test to convert, and follow up sexual health testing as well. So the visit schedule, this is just to review this again. The first is to determine the risk of exposure, to assess the timing, to review the medications, to evaluate for any history of Hep B or kidney dysfunction in the person who was exposed. Testing, a rapid HIV, 4th generation, a metabolic panel, testing for various hepatitis, and sexual health testing. Medication, you can either provide all 30 days at that time or 4 to 7 days with follow-up. Most places are recommending to do follow-up and then come back in a week and at 28 days to see that adherence and tolerability of the medication has been established. And I think the other piece that's critical is start to think about this piece at the end of the education, which is starting to integrate that person who's on PEP with a navigator to start talking about pre-exposure prophylaxis, PrEP. I know the next speaker is going to speak about PrEP, but I think that PEP in many ways is the gateway to to PrEP, because the person who's on PEP has already shown that they have high risk activity that's resulted in, for the most part, high risk exposures, qualifying them as a candidate for PrEP. The day 7 assessment, you don't necessarily need to do testing at that point. Provide medication, treat any STDs that you found before. If there's vaccinations that are relevant, and just have the follow-up and talk about all the side effects, talk about adherence. We know that in healthcare providers who have needle sticks, the rate of adherence is less than 50% for healthcare providers taking their post-exposure prophylaxis. We can therefore speculate that among patients, it could be even lower. So really kind of asserting and supporting the patient in their approach to have good adherence and to stay on the regimen is critical if they're going to really maintain the ability to stay HIV negative if they've had an exposure. Day 28 assessment, at that point, we do testing again, offer the transition to PrEP, which isn't done nearly enough, provide PrEP medication if the patient's interested, and make sure that we follow up with all the HIV, HCV testing, and talk to them about acute HIV and other exposures. And again, let them get linked back into PrEP care. So for the PEP to PrEP cascade, there are alternatives to oral regimens. Patients who are at risk for ongoing HIV exposure should be offered PrEP. And really, the key piece about PEP that I think we're talking about today is to make that moment a teachable moment. That's the moment when patients start to realize their vulnerability. They're not as super and strong and invincible as they would like to be. And this is the moment where they realize that things can happen that they didn't plan for. And so PEP is something that usually people will start out of a reflex because they know that they can do that to prevent HIV acquisition. But the next step to go on to PrEP is not really a reflex. That's more of a decision. And I think that decision is one that we have to really support patients in understanding. So the options are FTC TDF for MSM or heterosexual men and women and people who are using IV drugs. Creatinine clearance has to be greater than 60. FTC TAF for those not at risk for acquiring HIV from receptive vaginal sex, or creatinine clearance greater than 30. And then there's the use of injectable cabotegravir every 2 months for any adolescents or adolescents at risk for sexually acquiring HIV that weigh more than 35 kilograms. There are advantages and disadvantages to oral versus injectables. Obviously, injectables have been shown to be superior statistically to the use of oral agents, but they require ongoing administration, while as oral agents can be scaled by patients. Injectable agents, when used, patients have to go on oral agents for a year after that, while as oral agents, they don't have to do that. On the other hand, the use of the injectable agents is more likely to be efficacious if patients have wobbly adherence. So there's advantages. So the pluses and minuses of these two approaches have to be discussed with each individual patient. Now, let's talk about some of the work that's been done looking at PEP and the transition to PrEP. I'm going to present two studies. The first is a study looking at the sexual health program in London, the Dean Street Clinic, where 98% of the PEP users were MSM. PrEP uptake has increased 35% in the last year, with PEP uptake decreasing by 40%. And the most common day for PEP was on a Monday because of the weekend. The highest risk exposure was unprotected anal intercourse, which made up about 88%, and insertive making up about 10%. The majority of the exposures were people who did not know their HIV status, and chemsex was commonly noted along with that. And half of the individuals, only half, on PEP transitioned to PrEP, and 12% had been on this prior to exposure. So this goes to show you a clinic where everything is going well, where patients identify themselves at risk, and still only half of the people went on to PrEP. In DC, we've developed a hotline where I work, and I just want to talk about this for a second. We really followed a lot of the work in New York City that was done. And in our hotline, the main PrEP formulary is either once daily dolutegravir and TDF-FTC or twice daily raltegravir and TDF-FTC. There's a 24/7 hotline, so it's not based on when it's open, but when people call, and this is staffed 24/7. There's a plan to look at this. I can share these slides with those later, which helped us look at how we're planning and how implementation is occurring. The bottom line was patient calls the hotline, they're screened by a clinician. If they can't come in the same day, 5 to 7 day NPEP is called into a pharmacy that we've agreed to use. They come in the next business day to do their testing when the clinical visit and 28-day follow-up is done. So the point is we provide PEP without a visit and testing just to get them started, and then we'll go on and get the testing on the day following. In this, we found that the increase in NPEP starts compared with pre-implementation, we had a big increase, almost a tripling, and a big 92% versus 54% utilization in this population. Clients are more likely to come back, and we had no seroconversions. So I think the key piece of this program that you could understand that would be applicable where you are is the idea of getting them the medicine quick before they have to come in for a visit, which increases the stickiness, if you will, or the attachment of patients to be able to get access to this in a rapid fashion and then get the testing done the next day. The demographics of our population, about 74% were cisgender male, 25% cisgender females, 58% were seen as lesbian, gay, or homosexual, with about a quarter straight or homosexual. In DC, we had a higher prevalence of African-American, non-Hispanic, or Black patients. And you can see the rest. 97% of these patients had condomless sexual encounters, and about 2/3 of these were anal split, and about 2-to-1 for receptive versus insertive, but about a quarter had vaginal sex. This was the cascade of how many people stayed on. So again, we only did about as well as Dean Street, where we still had about a 50% follow-up of people who finished everything. So not perfect, but not bad. And then the big issue is that, 73% starting PrEP, and then this 46% of the group who made 28 days of PrEP. So a little bit better than Dean Street. Take-home points for you all today is that current guidelines recommend post-exposure prophylaxis has to be done within 72 hours of exposure. 2 different regimens it can be done with: once daily DTG and FTC TDF, or twice daily raltegravir and TDF FTC. There are data certainly to support the use of bictegravir and taf's FTC as single tablet regimen, but it's not currently part of the guidelines. And following a 28-day course of ART for post-exposure prophylaxis, PrEP should be strongly considered if indicated and the patient is interested. That is the end of my talk. I thank you all for your attention. Thank you very much.